Okay, I think we are now live. Okay, good afternoon to all. I'm very happy to greet you. My name is Tena Nisateo and I'm a member of AHP committee, and I have the great honor today to on a way conduct this webinar. Thank you all for joining to ESPEGAN AHP webinar. Today's topic is food insecurity, implications for child and public health. Our speaker today is pediatric and public health doctor from UK, Professor Marko Kerac. Professor Kerac started in global nutrition in 2003 in Malawi, when he first started in community management of acute malnutrition programs, which began to roll out there in Malawi. Yeah. Last 10 years, Professor Kerac is at London School of Hygiene and Tropical Medicine, combining research and teaching on the nutrition for global health. Professor will talk today about food insecurity. As we all know, the crisis of climate change and conflict are causing major disruptions to food security and are affecting millions of children worldwide. What is very disastrous for child health, given the most immediate risks associated with malnutrition. This is, of course, also has major implications for future adult and public health. So this talk will discuss causes, consequences, and above all, will try to highlight potential ways forward to navigate difficult times ahead. Before Professor starts, I would like to encourage you to ask questions in Q&A section or chat, and the professor will answer them at the end of his talk. Professor Kerac, I give you, the floor is yours, yeah.
Thank you very much, and thank you to you and all the ESPEGAN committee for your kind invite, and thank you to all of those who are joining remotely. Really appreciate your time. So yeah, my name is Marko Kerac, and a pediatrician and a public health doctor by background. And I had the great pleasure of giving this talk just a couple of months ago in ESPEGAN Milan. So at the meeting there, I hope some of you were also there and enjoyed. And what I've tried to do is also just expand it a little bit with slightly more of a focus on Europe as well, reflecting on what this means for us in more resource-rich parts of the world. And with the background in Milan, I want to start off with this picture, which clearly a tourist highlight of Milan, which I had the great pleasure and privilege of going to see, the Last Supper. So it's about food. And our guides at the time described it. This was the moment, capturing that instant when Christ was betrayed, and it's the emotions, but also the actions of the soul. So it's how each apostle reacted at that moment, at that time, when they realized what had just happened. And it's, again, a long story, it could be a whole lecture about the art, but what I want to put to you is, how are you going to react? How are we, as a pediatric child health community, going to react to this time of food insecurity, to another Last Supper? Will it be our last? How will we respond? What will we do by way of tackling the problems? So I have three key messages. So number one, that food insecurity is a major global health problem and is worsening. Secondly, that it has serious adverse effects on children, both short, medium, and long term. Thirdly, that it can be defeated. So effective interventions do exist, but will we have that emotion of the soul? Will we have that drive, that motivation to actually make sure those things happen? And towards that, politics, research, and your input is vital. So those are three key messages. And let's start with the first, food insecurity. So it's always helpful to start with a few definitions. So hunger. Hunger is an uncomfortable or painful physical sensation caused by insufficient consumption of dietary energy. So all of us have had periods where we're feeling hungry, but thankfully, I think very few in this audience will have had food insecurity. And that starts off on a scale. So we start off uncertain regarding the ability to obtain food. So that's mild food insecurity. That can get worse. So compromising on food quality and variety. Worse still, reducing food quantity, skipping meals, often also associated with decreased quality of the food that is there. And then when it starts getting severe, then that starts to be no food for a day or more. And when people, when families, when communities are totally running out of food and having to severely ration. That's clearly related to malnutrition. And malnutrition, again, a few key definitions, is any condition in which deficiency, excess, or imbalance of energy, protein, or other nutrients adversely affects body function or clinical outcome. And there are many ways that malnutrition manifests. So the commonest ones, and the ones that we often think about when people say the word malnutrition, are stunting. So when a child is too short for their age, when the height for age is too low. Wasting, when they're too thin. So the weight for height is low. Underweight, when the weight for age is low. But then we also have a form of other severe malnutrition called kwashiorkor edematous malnutrition. So that's when you get swelling. There's also micronutrient malnutrition, and that can be broadly divided up into those with specific symptoms, for example, iron causing anemia, vitamin A with the eye symptoms, vitamin K with the bleeding. But then many micronutrients don't have any specific syndromes, but they do impair health. They do impair they do impair well-being, and they impair growth. And then finally, it's really important to also remember that overweight and obesity are also types of malnutrition. So that's the opposite side from undernutrition, over excess. But important to also note that these forms can coexist, and it's very easy and does often happen that we get, for example, micronutrient malnutrition in the context of overweight obesity, if people are just eating very nutrient dense but low quality, poor diets. So those are the main types. So this is one of many maps. The Food and Agriculture Organization publishes a atlas of hunger, food insecurity worldwide. And unsurprisingly, this map of food insecurity, so the darker colors with the greater prevalences, maps fairly closely onto similar maps of undernutrition. So as countries, as regions, as communities get more food insecure, the prevalence of undernutrition is more likely to strike. This is another way of looking at it. So if you haven't seen this, it's a fantastic resource, World Mapper. So looking at the world through a different lens. I think we're all used to looking at a map, a geographical map. But what this fantastic resource does, it scales a problem by the proportion affected. And here we can see not just the country size, but by the prevalence of underweight children in different regions of the world. So you can see in North America, Latin America, Europe, relatively low. The big burden of disease in Asia, Africa, Southeast Asia. These are old figures from 2002, but still a broadly similar pattern applies today. And sadly, this is a historical problem. So some of the earliest descriptions of food insecurity when that becomes severe, termed famine, in history is in 331 BC. So we have this famous Egyptian famine stela, the carving of the famine. And as clinicians, as scientists in the area of nutrition, we should also be, I think, proud of the fact that actually one of the first trials, the first clinical trial in recorded history was on nutrition, 600 BC, approximately in the book of Daniel, where Daniel refused the Syrian king's food and assigned his youth a sample size of 10, so very small, to a diet of vegetables and water and improved health. So famine, sadly, is old. It's been around for a long time. All of us are survivors of famine, historically, genetically. There are more recent examples and other causes of famine. So the Egyptian famine, climate-induced. Then there's politics and colonialism. So the Irish potato famine, for example, 1845 to 49. Then there's totalitarianism. So one of many sad examples of this in Ukraine interwar, 1930s, totalitarian related famine. Conflict, war-related famine. So this is a map of Europe after the First World War, and my own country, my own home country, Serbia, heavily affected. And it's just I think a sobering reminder that all these causes are still around today. So we're still threatened by climate change. There's still politics, there's still totalitarianism, there's still conflict. So all of the things which caused famine in the past risk resurfacing, and sadly have resurfaced. So how many victims have we had over the ages? So you can see this is a map of famines recorded famines since the 1860s. And a few key things you can see here. So in the 1920s, so post-war, around the 1940s, again, conflict-related. One of the biggest single famines in human history, the largest standalone famine, the Great Leap Forward, so somewhat ironically named famine in China in the 1960s, resulted in 16 million deaths. So since then, thankfully, the numbers have been decreasing, but still a serious issue and still affecting many parts of the world. And it's very much the the great social evil. So the four great threats: war, famine, pestilence, and death, joined sadly by a fifth these days, misinformation. But you can see how lots of these factors have been around for a long time, and again, sadly, in many places, resurfacing, sadly being a threat again. So in the UK, during the war, there was a big report on the nation's health highlighting want, and again, part of that being the undernutrition, squalor, idleness, ignorance of disease as being the five great social evils. And we have five great modern evils. Again, hunger is still there. So still in 2022, hunger is still there as a top issue. And what are the challenges? So we've mentioned these just now, and we've got the three C's are commonly talked about: climate, conflict, COVID, infectious disease. But also more recently, I think really seeing the effect of chaotic, corrupt and incompetent leadership, incompetent systems, how these combine in a perfect storm, in a perfect problem to produce challenges to global food security. Another map showing how that issues of climate change, conflict really overlays and really underlies and precipitates areas which might otherwise have pulled through into becoming food insecure, into having high levels of undernutrition. So those really overlap: conflict, climate, and food insecurity. Globally, some 1 in 9 people are hungry or undernourished. So that translates to some 820 million worldwide. Conversely, 1 in 3 people are overweight and obese, the other side, the flip side of undernutrition. So really striking, really stark, really concerning figures. But what's especially concerning is that we're not making enough progress. So these days we have the Sustainable Development Goals, targets for 2030. Some of these targets even sooner, for 25, that's next year, and we're far away. So on stunting, so that when children are too short, on wasting when they're too thin, on overweight, too large, all of those sadly off course. So progress is being made, but nowhere near fast enough and nowhere near broad enough in a large enough number of countries. But given this audience, I think also important to remember that it's not just a factor elsewhere. It's not just in the more resource-poor parts of the world. It also affects us in Europe. So moving beyond children, in Europe, some 33 million people are malnourished. And that includes some 1 in 5 children admitted to hospitals, 1 in 4 patients in hospital, 1 in 3 cancer patients, 1 in 3 patients in care homes, and 1 in 3 older people living independently. So it's not just a problem elsewhere. It's not just a challenge elsewhere. It's also a challenge here. And it has big costs and has big implications. So if it's cost that's the main driver to do something about it, it costs some estimated 170 billion a year to European countries alone just to deal with malnutrition in our own setting, in our own communities, in our own societies. So big issue even here. So I found this recently. So this was a paper looking at the prevalence and trends of underweight in children and adolescents in Europe from 2000 to 2017. And sadly, it doesn't look good. So yes, we do have a huge problem of overweight, obesity. That's really the major form of undernutrition. But it's striking and it's sobering. It should make all of us stand up and take care and be alert that concurrent with that epidemic, and we call now the double burden of underweight and obesity together, that even in Europe, we have large prevalence of underweight. And it's not necessarily the countries we'd expect. So it's not always the poorest countries who have the greatest levels. Highest income countries are also affected. So again, a really hugely shameful statistic. So UK in 2001, the 6th richest country in the world, and yet high levels of households facing food insecurity, empty food cupboards, empty fridges, wondering where the next meal is going to come from. That's mirrored by the rise of food banks. So again, this is UK. I haven't got the data for elsewhere, but really striking. Remember, the 6th richest country in the world, and we've got this huge rise of food banks. So where people are coming, where people don't have money to buy themselves, so having to come to these charities who do provide food, who provide that emergency safety net. And again, we're very proud to have Anne Elkins here in the photo below, who's one of our ex-students at the London School, who's one of the senior managers there, who's doing a fantastic job with the Felix project, so running food banks. But surely it shouldn't be a thing that's needed in high-income countries, and yet it's there. This is another sobering report. So just recently, around the election time, the Food Foundation put out a report looking at health and well-being of children in the UK. So yes, we've got the striking statistics about obesity having increased by 30% since 2006. So that's a major problem. And that has consequences. So it has consequences. There's more diabetes. Children born today will enjoy less good health than children born a decade ago. And particularly striking is this figure on the right, where we can see that the average height of children has not only not carried on increasing, but it's actually gone down. So when I first started working in this field, when I first worked in Malawi in 2003-04, I always thought I'd be the last generation working in the setting of undernutrition, that the world would change, that even in resource-poor countries, things would shift towards overweight, obesity, a really important form as well, but largely the undernutrition, stunting, these other forms of under would be gone. However, it seems now that the need is not only elsewhere, like in Ethiopia, Malawi, countries where I'm working at the moment, but the need is actually very close to home. So with stunting, with heights going down in both boys and girls over the last 10 years in the UK. So really striking, really sobering, really concerning, and a real need for action to address this. Why is it important? Second key message is that food insecurity has serious adverse effects on children, on short term, medium, and long term. So in the short term, the thing that we're most concerned about is survival. Globally, some 4.9 million children die each year. Now, as you can see from this pie chart, the vast majority of these deaths very easily preventable using known technology. So we don't need new drugs, we don't need new technologies, we don't need new approaches. We just need to deliver what's already there, what we already know. And think about it, that equates to 13,000 per day. That's 45 airliners crashing each and every day. And we know how much just one airline tragedy hits the news, carries on in the news. And yet we've got this ongoing cycle of mortality that nobody's talking about, few people are noticing, few people are caring about, few people are investing in. That needs to change. Undernutrition. in all its forms contributes to some 45% of these deaths. And some forms of undernutrition, severe wasting, for example, or wasting overall, contributes to almost 1 million deaths. So really striking figures. And what we're saying there is a child who has pneumonia or malaria or measles, if they're well nourished, yes, it can be a serious illness. Yes, it can be life-threatening, but they're far more likely to survive than a child who's undernourished and gets the illness, and they're very, very high risk. Firstly, they're at much higher risk of getting the illness, much higher risk of getting diarrheal disease, pneumonia, etc. But also when they do get it, their chances of actually surviving it are correspondingly much lower. So the number one reason why things matter are because of mortality and the impacts on that. But it's not just survival, it's helping children survive and thrive as well that really matters. So child development is key. And this is an old study, but again, hugely powerful and hugely important to note. So this is looking at the effect of food supplementation and then stimulation, so child development, play therapy, etc., on children. So without any intervention, the control group. So this on the y-axis, we're looking at the development, and on the x-axis, looking at time. So we can see without anything, the control group, so their development is markedly decreased compared to the non-stunted normal children. With food, things improve. With just stimulation alone, things improve as well. But it's when you combine the food and the supplementation together, that's when things make a real turn for the better. So it is food, but it's also the wider environment that really, really matters. So it's both and, not either or. So nutrition matters for child development. And that has implications down the line. That has implications for school. So we want to give our children everywhere worldwide the best possible start in life, because they're going to be the next generations of doctors, lawyers, teachers, etc., all the many, many professions, people, trades that we need to have healthy, functioning, cohesive societies. So we need to give children the best possible start in life. And as you can see from this, those early years, especially the first 1,000 days of life, that's the real opportunity. That's when things really make a difference. And that's when we need to intervene to give people the best opportunity to make the most of things. Because sadly, globally, some 200 million children under 5 are failing to meet their developmental potential. And they go on to do poorly in school, to have lower incomes, not have that same opportunity, not fulfill their full potential in either school or in adult life. And in turn, you can see how that cycle can very easily continue, providing poorer care and suboptimal care. So that intergenerational cycle of poverty. There are also long-term impacts. So more and more now, and through studies, quite a number of which are in Europe. So some really important and inspiring work following survivors of the Dutch hunger winter during World War II, where we're seeing that those exposed to undernutrition in utero and in early infancy especially, the survivors are also affected. So they have a greater risk of non-communicable disease, heart disease, diabetes, even cognitive mental health conditions later on in life. So it really makes a difference, not just short and medium term, but also long term. And if we want to tackle things which we traditionally associate with obesity, overweight, we also need to think about children and optimizing their nutrition. And this is just one of several reviews. So one recent review that we did looking at neurodevelopment following early child undernutrition. So that's affected. This is another paper, again, if you're interested, have a look, looking at the effect of severe malnutrition or famine exposure on later life non-communicable disease. And so what we can see is a very consistent association with cardiovascular disease, hypertension, with impaired glucose metabolism and metabolic syndrome. The association with lipid metabolism slightly more mixed, and with obesity slightly more mixed. But again, remember that the early life undernutrition can also predispose to later life obesity. So big implications, and it matters not just now, not just short term, but for the long-term future. And it matters because this is some of the things that we're exploring at the moment in one of our other projects. So this is the capacity load model put forward by Jonathan Wells and colleagues at University College London. So they talk about capacity and our capacity to deal with insults, to deal with environment, to deal with foods, being really modulated and really affected by issues that happen in utero. So you might get adverse exposures in utero, so that's adverse hits. Another adverse hit would be child malnutrition, and another adverse hit would be suboptimal treatment. So if you have those bad exposures early on in life, what that does, that reduces your body's capacity to deal with risks, to process those risks. And over time, risks accumulate. So we have loads, we have stressors, including poor food, poor environment. And once those stressors, once that metabolic load exceeds our body's capacity to cope, then that manifests as non-communicable disease. So early life nutrition, making sure that it's optimal, has a huge role to play, because otherwise, I think one other way to look at it, it's a bit like developing the body from the word go. Otherwise, you've got the equivalent of a very small organ, very small metabolic capacity, small organ capacity, pulling along an awfully big load. And you can see why the small car pulling a big load gets burnt out very, very quickly. Whereas if you developed that, if you have that early capacity, things are much better in both the short, but also the long term. So this is some evidence about the effects and the age sensitivity of early life famine and food insecurity exposure, looking at survivors of the childhood famine. So we tracked them and we divided them up into those who'd been exposed in utero, and those who'd been exposed later on in life. And what you can see from the graph here, I'm not sure if my pointer's working, or my hopefully you can see my mouse, but you can see that the exposure in utero and in the first 1,000 days, so in that first 1,000 days sensitive window of exposure, the risks of those longer term implications are the greatest. But there are also risks of exposure in preschool years, in primary school, and even in adolescence. So those risks continue throughout life. So it's the early years that count, but throughout childhood, really, really, really important. And that's why, again, if you're interested, one of the many initiatives and that started off in the humanitarian context, that started off in low-income countries, but we're realizing is increasingly relevant to high income as well, is about optimizing infant nutrition, infant well-being. So that really matters to give everybody the best possible start. And it's about those life cycle opportunities. So do we see it as a challenge, or do we see the same thing as an opportunity? And combining those, maybe a opportunity. Because what you can see is that life cycle risks can very easily be magnified. And so you might have a baby who's born low birth weight, who doesn't have optimal nutrition, who has inadequate catch-up growth, who then grows up to be a child who's stunted, who grows up to be an adolescent who's stunted, who grows up to be an adult who hasn't achieved their full potential, either physically, cognitively, and that continues throughout not only an individual's life cycle, but has intergenerational effects. And the way that can be tackled is by really focusing on the first 1,000 days. So they're particularly sensitive, particularly important. But there's also the second window of growth in adolescence. That also really matters. And how can we address and how can we improve the nutrition in that second window of opportunity in adolescence? And finally, but also hugely, hugely importantly, how can we support mothers, vulnerable adults, those with disability, for example, to also optimize their nutrition and to try and break that cycle, that life cycle, that intergenerational cycle of impairment of risk? Because this all has implications, and it has implications for individuals, for families, for communities, and for whole societies. Which leads us on to our last point. Food insecurity and malnutrition can be defeated. And it's important perhaps to start off with the local actions. So what can we do? So I presume many of you will be clinicians working in European settings. Simple things we can do to respond to the issues that we have in Europe is screen and monitor patients for malnutrition. So sadly, that really doesn't happen nearly as often as it should. Easy to do. Unless you see a problem, you can't react to it. So screening and monitoring patients really makes a difference. Providing timely and effective nutritional care. So working with food to improve nutrition, working with medical nutrition products, so with specialized products to also improve nutrition, that matters. Thinking about multidisciplinary teams, so having a dietitian and nutritionist as a core, really important part of the ward round, as important part of the clinical care, that makes a big difference. Educating and being an advocate for nutrition, both for fellow health professionals, for patients, for many others. So simple things that all of us can do. We can also widen our actions and thinking about other circles of professional influence and control. So this is a really nice document recently completed in the UK by the Association for Nutrition, where they're setting a curriculum for all medical students in the country to have nutrition as part of their studies. And you can see that malnutrition, so underweight and undernourished, is one of 6 core topics. So really important to have it as a core thing, which we just do in basic clinical training, basic nursing training, basic training. So getting it there on the map. And I think all of us will remember our student days and that old maxim, if it's not in the exam, people won't take it seriously. If we make it in the exam, if it's an official part of the curriculum, if it's there, people take it a lot more seriously and it can really make a difference in the longer term. It's also an issue about medical career choices. So do we focus just on the ultra specialized conditions? So this is an old book, but it's still relevant, which I just found the other day when I came back from leave, written by one of the first professors of global child health, David Morley, and his colleague Hermione Lavelle. So we're looking at, how do we as a healthcare community respond? So are we focused on the disease palaces, or are we really focused on how to make nutrition in the wider community, health in the wider community better? So how can we steer our younger colleagues, those coming up through the system, to actually make a difference, not just to their patients in the high-end hospitals, but to all people in the community? But ultimately, it's down to politics. So as I'm sure everybody knows in the UK, and as I'm sure everybody's been hearing in the UK, if you elect a clown, expect a circus. And we need to also engage with politics. And it's sobering in the UK that recently it took a footballer rather than politicians to reinstate free school meals for children. So it's something which is a global program. Many, many countries do it. And it took a footballer's campaign to make a government policy to give children who need it free school meals. So it does boil down to politics. And it boils down to doctors' roles and clinicians' roles and health professionals' roles as social activists, because we do have a big voice. People do listen to us and trust us in a way they don't trust politicians, they don't trust other parts of society. We have a big role, big responsibility, and can make a difference. This is one such doctor activist. So John Boyd Orr, so he was the Director General of the first Director General, the founder of the UN Food and Agriculture Organization, and he won the Nobel Prize post-war for his lifelong effort to conquer hunger. And one of the reasons why he got it on the map, and one of the reasons why he persuaded politicians of his time post-war to take food insecurity, to take nutrition seriously, was with this reminder that famine, food insecurity, is the greatest of all politicians. So we cannot build peace on empty stomachs. So in order to think about societal reconstruction post-war, post the Second World War, we needed to have a well-nourished population. So that's his great insight. And I think that's really important, every bit as important today, but also a big danger that it's being forgotten. And again, I think another nice quote of his, that there can be, and an important quote, there can be no peace in the world as long as a large proportion of the population lack the necessities of life. World peace must be based on world plenty. So nutrition is really key. So what kind of things can we do? What really matters? So there are 4 dimensions for food insecurity, all of which need to be addressed. And again, as you see, this is very much about political actions, social actions. There's the physical availability of food. There's the economic and access to food. And again, food banks are a temporary solution, but they're a sticking plaster. They're not the definitive solution. They're not a long-term solution to that. Then there's food utilization. And again, we can make a difference with that, how we treat our patients, how we educate, how we engage, and do we, as a health community, take food and nutrition seriously? And then finally, are these 3 stable over time? Climate and crops and agriculture is clearly a big thing underlying everything, and it's the biggest threat of our age. And it's not only threatening in the short term, it's civilization threatening, it's planet threatening, and we need to focus on agriculture, climate. So that's a big, big priority. But also thinking about what else can we do. So that is important, but that's beyond the scope of what many of us do. One thing that we can do is think really carefully and think hard about how we talk about malnutrition, how we relate to it, how we measure it. And one of the big things, and one of the things great to remember from this talk, is that we need to focus not just on children's size, on how big or small children are. And we don't really care if they're big or small. We care that they're healthy, that they're well, they're growing well, they're developing well, they're doing well in school. So that's what we need to focus on. That's why the term severe malnutrition matters. And it's about using that as a reminder that severe malnutrition has both those ends of the spectrum, both the undernutrition, but also the overnutrition, and the one in between, the micronutrients. So they all matter. They all make a big difference. And we need to get better. So this is something we can do through research and measuring things. So not just measuring body size, but also measuring function associated with that. These are some things that we did in some of our studies in Malawi. So as well as measuring size and growth, we also measured physical function. So we looked at a step test, so how active children could be, how much physical function they could perform. We measured hand grip. So again, another really, really good tool to measure physical function, physical activity. We can focus on the measures of cognitive development. So we were fortunate to have MRI. So we did an MRI study. So there didn't see a difference in some of our basic cognitive testing, didn't see a difference. But where we did see a difference was in school achievement. So this was a follow-up study looking at how children who are malnourished when they were aged average under 2, how do they do 7 years later? How do they do now 15 years later? And so school achievement was not as good as it could be. And we need to measure things that matter. So as well as size, as well as growth, also thinking about health. So again, simple things we can include in our studies, in our research. So metrics of health and well-being. For example, how many outpatient visits in the last 6 months, how many hospital visits, what kind of symptoms did they have, and really thinking about what does it mean to be well, and as well as the hard, easy to measure anthropometry metrics, also thinking about health metrics and prioritizing those. A few other things that can help are measures of body composition. So this is another field which has really advanced very quickly in recent years. And so body size, body mass index alone is important. It gives us an important clue what's going on, but it's not perfect. And what we need to do is think about measures of body composition. So few places will have the luxury or the time or the resources to do DEXA scans or air displacement plethysmography. But important things to highlight that some technologies like bioelectrical impedance are becoming a lot cheaper, a lot more widely available, a lot easier to do, and really give us a great insight into what's going on body composition wise. So really important step forward in that. But what can we do? I think the big thing is that we need action, not just at one level. So there's no one silver bullet, easy magic solution. Action is needed across multiple levels. And so here we have the UNICEF Child Survival Framework, and it reminds us that we need to have diets which are good and high quality and adequate quantity as well, but that's also combined with good care, and that needs to be combined with adequate underlying determinants. So things like good availability of food, feeding practices, high quality environments, that's underpinned by enabling determinants, good governance, good resources, social norms, encouraging good nutrition. And broadly speaking, we need both nutrition-specific and nutrition-sensitive actions. So nutrition-specific actions can include, for example, school feeding, can include community management of acute malnutrition, CMAM, includes community cooking demonstrations, promotion of good infant and young child feeding practices. So these are examples of nutrition-specific actions. And they're all easy, and breastfeeding is another one of them, but it's delivery that's the challenge. So coming back from a meeting in Geneva sometime, I think you can't not be struck by the many adverts and by the watch industry and by the time industry in Geneva. So time, of course, is immemorial. So time belongs to everybody. The first people who started measuring time were the Sumerians, and this is an ancient sundial from, I think, 6000 BC, so very old technology. And the Swiss, in more modern times, started measuring it with a greater deal of precision. The thing is, in the 1970s, digital watches came along and threatened to undermine the Swiss watch industry. So having been successful for many decades, Swiss watch industry was suddenly under threat. And what came to the rescue was not the tech, but the marketing. And the marketing of watches like this, the famous Swatch watch. So this is one of the first ones. I remember having one of these when I was young at school. And it's the marketing that makes a difference. And it's the marketing that defeated the digital watch that makes watches like these sell for really quite eye-watering amounts in Swiss shops, in luxury shops worldwide. And yet for other technologies, so for breastfeeding, think about it. If breast milk were a farmer intervention, it would not just be a multi-million or a multi-billion pound bestseller, it would be a multi-trillion pound bestseller. And yet we're just as bored of it as this guy seems to be. The industry has much better marketing, much more drive, and we need to counteract that. We need to also think about how do we promote things that work like breastfeeding. So how do we have powerful, effective, engaging public health messages? So how can we really make the change? And if you haven't seen it, do check out this really important series on commercial drivers of health and how commerce, how marketing, how companies do a huge amount of damage to undermine feeding and infant feeding worldwide. A few other final things. So we need to reflect on the fact that sometimes slow and steady growth may actually be a good thing. So typically people who are undernourished, our response to that is try and feed them as quickly as possible with as much as possible. But this is some evidence, so do have a look, that actually slower, steadier growth may be better in the long term. And the eagle-eyed among you will, of course, spot the confounders here. So slow but sure, Mr. Kazembe here in Malawi may have got it right in terms of his science, but there's a big public health threat on his sign. So all the high energy drinks, all the anti-nutrients, all the high all the harmful foods that also come are a big threat. But just remember that it's slower growth, slower recovery may actually be a good thing. We also have many nutrition sensitive actions. So things like improving the agriculture, having social safety nets, women's empowerment, better education, better water sanitation. So these are all things that indirectly affect nutrition, food security, but are hugely, hugely important. And it needs to be a package of things that comes together. And ultimately, we need to move it beyond partisan politics. Hunger is wrong. So hunger has always been wrong. It was there in the ancient world, it was there at the start of the modern age, it was there in the 1930s, it's still here in the world today, and it's wrong. And we need to move beyond partisan politics, actually making positive points. It's not how much does it cost us to tackle hunger, but what are we losing? Why are we not tackling it? It's a fantastic investment. So there's an estimated $16 return for every $1 invested in nutrition, and it affects many, many social, environmental, and wider social health and wider outcomes. So it's really key to many of the sustainable development goals, and it's a fantastic investment. And we need to see it as an investment, not a cost. And rather than asking how much does it cost and can we afford to do it, is can we afford not to do it? So we must act, but the time is short. So just remember that we do have enough interventions. To scale up new interventions takes an average 10 years, so there's not a lot of time. We have to act fast. There's lots of work to do, but there are lots of things we already know work that just need scaling. So the time to act is now. So what will you do? So we started off with our picture of the Last Supper, and we all know the stories of the apostles after that. Again, in the wonderful museums of Milan, there were other apostles, and a big call to what each of us will do. So what can be our role? However big, however small, it all matters. It's all cumulative. It all makes a difference. And again, from that time in Milan, I remember this very, very nice quote about literature, about poetry. And I want to end on this. So where power corrupts, poetry purifies. And it's a great quote from Gabriela Mistral, reminding us of how important things are and how important it is to get nutrition, food security right, especially in early childhood. We are guilty of many faults, but our worst crime is abandoning the children, neglecting the fountain of life. Many things in this world can wait. The child cannot. Right now is the time his blood is being made. Right now is the time his bones are being formed and his senses being developed. To him, we cannot answer tomorrow. His name is today. So 3 key messages. Food insecurity is a major global public health problem, has serious effects on children, and it can be defeated. Thank you.
Thank you, Professor Kerac. It was a very interesting and very comprehensive talk. And I think really we need to talk more about malnutrition as much as we are talking about obesity today. But as you said, the advertising and the media have forgotten a little bit about malnutrition in the world, and I think are not aware. They are not aware. The people are not aware. Even the people who are in the experts in the field are not aware how many people are malnourished or undernourished in Europe. I cannot see here any questions, but this is probably because for me it was like I had 10 questions, and every time you went away with your further with your talk, you answered on the question. But I have 1 or 2. You are a researcher also, and I was thinking, do you know of any projections in the future, so projections of the future of the development of famine or starvation in the world in regard to climate changes and technology changes and everything?
Yeah.
Do you know about?
I think that's a fantastic question. So, so pardon me, I have a bit of a cough. There are, I don't know if projections in the long term, because lots depends on how we react and how we react now. I think what I can say is that if climate and conflict and other things continue at this rate, it's looking very, very bad. But even in the short term, I think what I always find sobering and striking is that we can predict. So there are great sites like the State of Food Insecurity and also FuseNet, the famine early warning system, which map out areas which are at risk of malnutrition, food crisis in the coming months, in the short term. And even though we have that great data, think sadly it's not acted on nearly enough as it might be. So it is a very sensitive thing. There are lots of politics, lots of diplomacy involved, but there are good projections, certainly in the short term. The longer term, I'm not sure of the details of it, but with climate overall, unless that changes, it's not looking good. I mean, really a big loss of productive land, of agricultural land, and also other things like displaced populations, drivers of conflict, etc. So many threats and a huge amount of work to do to improve things in the future.
And what do you think? What is the problem with media? And did they forget about starvation? Why is that there are no more like TV shows or talks about starvation, about the food insecurity in world, in Europe, in developed countries also? Because I never hear about this in the media or in popular, TV episodes or emissions. What is the problem to talk about the hunger because obesity is all over the place,
I mean, I think, again, a really great question. And I think I wish I knew that that's something which would make a big difference. And I think that's something that we as a nutrition community need to get much better about, and about highlighting the problems that do exist. And I think maybe one of the challenges, and I think where we should perhaps start, is by looking at undernutrition in our own communities, in our own countries, in the high income settings, because it seems to be that people are so preoccupied with things immediately on their doorstep, with all the problems that we're facing, the cost of living crisis, prices going up, with lots of issues locally. And it becomes much harder to remind people of the much more serious issues going on slightly further away. So I think maybe
sorry,
one good...
But you said that it is not so further away. In UK, in York, where you live, I didn't remember the number of the people who are undernourished and who are starving. So it is on in your backyard.
Exactly.
It's
I think that's a really important starting point there. Clearly it's not the same. It's not a widespread famine, but there are pockets, there are children who are heavily affected, there are children who are not achieving their full potential and who are having a very tough time. And that's perhaps where we need to start. And through that, actually remind that it's a global problem, and that unless we tackle it as a global society, it's going to be tough. And I think we're reminded of it now with the consequences of the conflict in Ukraine, which is a long way off, but at the same time affects prices in our supermarkets, in the other parts of Europe, affects refugees, affects how things are done, affects spending, affects ability, affects what governments do with their resources. So I think these things are very, very heavily interlinked. So I think we need to see those interlinkages. We need to figure out how they relate to each other and really have a concerted effort on many different fronts simultaneously. But I think, yeah, I agree with you. There's lots that can be done even in our own countries to tackle the vulnerabilities, the underprivileged and underserved communities and families here.
Okay, we have one question from the participants. Can you, Professor, open the question and answers, or I can, you would like to for me to read it? Karyan Atwal asks, if more screening and monitoring are implemented in practice to detect food insecurity, how do we support those identified at risk with the current resources available?
Yeah, so I think a really, again, a very good question. There are resources available, and I think that's why that final point, we need to see it as not a cost, but an investment. And it has huge returns. That $1 invested has $16 of return in terms of later health, later well-being, social productivity. So many returns. So we need to keep making the case for why it is a good investment, a wise investment. Even just, I think, opening up the conversations, even identifying the problem is a really important start. Because if we don't look for the problem, if we don't even see it, then the conversation stops even then. Whereas if we're at least looking at it, we may not have the resources that we'd want. we may not have the fullness of the options that we'd want. But as soon as we start looking for things, as soon as we start seeing more, that's when perhaps the conversations can change. That's when we can exert more pressure and lobby for more resources to be prioritized accordingly. And that's why we need to see it as that's saving for long term. And that's why those things like the longer term risk of non-communicable disease and long-term risk of poor health really, really matter.
Great. Okay, I think that's all. Yeah, we can wrap it up. Your talk was great. I was a little bit awakened and reminded about the other side of the coin of the malnutrition. Thank you very much for your time and for your great talk. And I really hope to hear you more to talk about this, not only on these congresses and the expert meetings, but for public to hear what is happening, to remind them that this is still a big issue in the world, but also in developed countries. Thank you very much. And
thank you very much. And thanks to all the audience for joining.
Yeah.
Thank you very much then.
Thank you, and thank all the participants. Join us on the next webinar of SPGAN HP. Thank you.
Thank you all.
Bye.